Donna is the National Nurse Manager with Lymphoma Australia, and she, as I said before, is based in Melbourne. She has over 25 years experience in haematology nursing and has spent some time also working in London. Donna returned to Australia and worked at the Peter MacCallum Cancer Centre for over 17 years in a variety of roles, including a specialist nurse on the haematology and transplant unit, a nurse unit manager, a nurse coordinator, and an educator on the chemotherapy day unit. And in addition to this, Donna held a senior role as a nurse consultant for the Victorian and Tasmanian Adolescent and Young Adult Cancer Service, also based at Peter Mac. Donna then moved from Peter Mac to implement the Adolescent and Young Adult Cancer Service at the Epworth Hospital in Richmond before joining Lymphoma Australia in 2017. So with that extensive wealth of experience, Donna is very well placed to take us through Chemotherapy 101. Over to you, Donna.
Excellent. Thank you, Beck, for that lovely introduction. Let's try and get my slides up. Oops. Oh, you guys see that now? Can you hear me?
Yep, I can hear you and see your screen, Donna.
Thank you. Sorry. It's a bit confusing. Hi, yes, thank you, Beck, for that lovely introduction, and thank you everyone for joining us today. We'll be talking obviously about Chemotherapy 101 and the basics, and trying to explain some of those common questions that I've received over the years from many patients, that it might help you understand why we're giving chemotherapy, how it works, because it can be quite complicated and a lot of questions do arise. So a reminder about the Q&A button down the bottom, and I'll try and endeavour to answer all your questions toward the end. But today we'll be discussing, thought we'd start with a bit of an understanding of the cell cycle, and this gives you a really good understanding of how the cell cycle works, why we do use chemotherapy and how chemotherapy has worked by understanding this cell cycle. And this also gives you a bit of an understanding of how cancer also develops as well, and of course of lymphoma. Looking at what is chemotherapy, how it works, and some of the factors that we look at for treatment decisions as well, and that can be quite complicated and very individualized. How chemotherapy is given, looking at some of understanding why chemotherapy protocols are what they are, why do side effects occur from chemotherapy, and we're just going to briefly go through a little bit some of the common side effects and how to manage those common ones, but we can answer those more individual questions you might have afterwards, might be, because that's a whole presentation in itself. Okay. So the cells are very, very important to thing to know about. But basically, these are the basic building blocks of all living things. All humans are made up of trillions and trillions of cells. And cells have many, many different parts, and also different roles as well. And they all function and work together quite in harmony. And it's amazing how well they do work, and little problems do occur, really, considering. They provide the basic structure of the body. They take in nutrients from food. They convert food into energy to carry out these specialized functions. Some cells tell other cells what to do, and other ones carry out these functions. But they're all designed basically to grow and to die in a controlled way. And cells generally do have a set lifespan. But unfortunately, when a mutation occurs and they don't die as they should, or what should happen, actually, they do die if there is a mutation. But if something goes wrong and this mutation does take over, cancer can occur. So I thought we'd just quickly look at the different parts of a cell, so it makes a bit more sense. So cells are contained in the body's contains all the body's hereditary information, and can make copies of themselves. And we rely on cell division to grow, repair tissue damage, and also just general wear and tear as well. It's inside, it's got the cytoplasm, a bit of a jelly-like sort of stuff, and it's full of all different nutrients, and also includes obviously the nucleus. And this nucleus is in the middle of the cell and it contains all of our genetic material and information in the form of DNA. And it's basically our command center and sends directions and messages to help the cells grow, mature and divide, and obviously die as well. Oops. We also have chromosomes, and each chromosome is made up of tightly wound DNA in thread-like structures. And basically we have about 23 pairs of chromosomes in our bodies. And these contain the DNA, and DNA can wrap around, I think, the Earth a couple of times. So there's a lot of DNA crammed into one little chromosome. And this is the hereditary material in all humans and all living organisms. And then we have genes. And genes are really important. They're the basic physical and functional unit of hereditary. And genes are made up of DNA, and every person has 2 copies. So they've received a copy inherited from each parent. And then the small differences in the sequences make up and contribute to our individual physical features, for instance. So if the nucleus sends the wrong orders and messages, the cells do multiply uncontrollably and eventually can form a cancer. So normal cell function, basically our cells are designed to grow in a controlled way. They mature properly before they go into division, multiply in a controlled way. Basically, every new cell equals or keeps an equal balance of our old cells and wear and tear of the old cell's death. They work together quite closely in harmony. They have a set lifespan. And if a cell is damaged and is unable to be repaired by the body, then there is a programmed cell death called apoptosis that occurs. In the cell, and understanding the cell cycle will answer some of the questions about how cells divide and where things can go wrong and where cancer develops. And it's also important to then understand how chemotherapy works on top of this. So you'll see this diagram a couple of times during the presentation. So basically the cell cycle has 2 different phases. It has the interphase, which is that blue phase around the cycle. And that's basically where the cells increase in size, where they grow, they replicate the DNA, and then eventually multiply in the mitosis phase, which is the M phase at the top there. So we have, we have firstly the G1 phase, which is the green, which is where basically the cell increases in size, the cells are copied, all their information is copied. And then there's a checkpoint here. And these checkpoints are very important, where they look to see if there's any DNA damage, any repairs made if needed, or they wait for orders to see it before they start to move into the pink phase, the synthesis phase. There's also the resting phase or the GO phase. And a lot of cells get to this point in maturation and the body decides, oh, look, we're not ready for you yet. We don't need any of you. You can go into the resting phase like a holding bay for when the body actually needs them. Say, for instance, platelets, if there's a trauma, you've got all these platelet cells, well, then will rush out and ready to start clotting factors, for instance. So they sort of sit there and wait. Some can wait there for many years. Some can wait there for a few hours, depending on what's going on. When they get the orders to continue with their development, they'll go into the S phase, where the DNA replicates into the 23 pairs of chromosomes. And this, there's another checkpoint at this point as well, just to make sure everything's still looking okay before they go into the G2 phase. And this is where the cells grow up more proteins develop in preparation for the cells to divide. And there's another checkpoint here just to make sure that everything's still looking good before they then go into the mitotic phase, which is when the cells separate and divide into 2 identical daughter cells, and the whole system happens again. But there is another checkpoint there as well, and the body checks to make sure there's no damage, quality control done. If everything's looking well, they'll continue on and continue dividing happily. If there is an issue, they'll try and repair it, or if not, they kill the cell off. In all this, there's these special genes called tumor suppressor genes, and they're really important. They're like the brakes of a car, so to speak. So basically these tumor suppressor genes, they stop the progression of the cell cycle and start repair throughout the cell cycle at these checkpoints for any damaged DNA. And if this DNA can't be repaired, then it then ensures the cell then goes under cell death, or apoptosis happens, and they no longer duplicate. And this is a safety mechanism our bodies have every day, repairing these and doing this sort of system. But when these tumor suppressor genes don't work properly, something goes wrong and these genes, the breaks are faulty, so to speak, and then uncontrolled growth occurs. And this, if they're mutated or whatnot, they can actually increase or the expression of what we call oncogenes. And oncogenes, you may hear or read about them, they're called P53 or TP53. And if these are expressed in high levels, these oncogenes are like an accelerator in a car. So they're stuck down. So the cells then start to replicate. If the body's unable to stop these cells, then this can actually lead to cancer. So it's been a very complicated and very entwined sort of process. So basically, a review: cancer is basically a disease of the cells. The cancer occurs when abnormal cells grow in an uncontrolled way. Cells aren't able to communicate. They don't die in a controlled way. And also, lymphoma is a disease, just a reminder of the immune cell. So a lymphocyte, so it's the type of cell that is abnormal. What is cancer? Chemotherapy. So treatment that uses the drugs to stop the growth of cancer cells. And this happens either by killing the cells or by stopping them from dividing through various parts of that cell cycle. So chemotherapy stands for basically chemical therapy. And you may hear a word called cytotoxic. And basically this means any drug that is toxic to the cells are going to kill the cells. And that can be chemotherapy, it can be radiation, it could be other immunotherapies that are toxic and kill cells. The history of chemotherapy is quite interesting. I'm quite interested in this part anyway. So basically chemotherapies have been around since about the 1950s. And starting off with nitrogen mustard and methotrexate and vincristine, doxorubicin. It wasn't until around about 1975 when they sort of thought about doing combination treatments for lymphomas, and ABVD was the original one there that started off before CHOP. And these are still quite embedded in a lot of treatments for Hodgkin lymphoma and non-Hodgkin lymphomas today. So in the late 90s it started the era of targeted therapy, and Rituximab, which is many of them have probably heard about, is a very embedded treatment in lymphoma as well. And this really set off revolutionised the treatment of many different non-Hodgkin lymphomas. And this has started off with a lot of different other immunotherapies that have been introduced. And more recently, we're looking at more immune therapies such as CAR T-cell therapy. So using our immune systems to try and fight cancer, doing the job that it should be doing, really. So how does chemotherapy work? Well, it does, it works by killing rapidly dividing cells, so such as cancer cells, and also unfortunately it does kill the healthy cells, and we'll go through that a little bit later, and that's why some of the side effects can occur. It's a systemic treatment, chemotherapy, and that's really good for something like lymphoma, where it's a systemic cancer. A lymphoma does spread right through our lymphatic system, so having a systemic treatment is much more attainable than having something like surgery. You can't just cut it out because there's all these little cells that we can't see. So it kills cells all around the body. Some of the lymphoma treatment decisions can be a little bit complicated. This can be really quite a difficult and frustrating time, because a lot of these tests and whatnot take quite a while to make sure the doctor has all the information that they need to ensure that they give you the right treatment plan. So really, most importantly, is having that right diagnosis of a subtype, where the doctors need to know the exact classification, because that can really affect what treatment or chemotherapy that they actually order for you. Thinking about some of the genetic profiles and also looking at the staging, so how spread the cancer is around your body, will it sometimes indicate what type of treatment they will actually treat you with. Some of the other prognostic factors that come in that were very individualised for each person too, they're looking at your age. So some of these chemotherapies can be quite harsh, intense, and we want to make sure we're not giving you any more harm than we actually have to. We do other blood tests like LDH and blood tests to see how your body's being affected by the cancer before we start. And this is, the LDH is looking at basically the enzymes or the cellular turnover in your blood. We can actually sort of test for to see how advanced basically your cancer is. We're also looking at the medical history that you have, your past medical history, to see if there's anything that may indicate what we shouldn't be giving you certain treatments. Obviously, general health, and of course, we would like to be ensuring that we have your decision and choice in there too. The aim of chemotherapy is very individualised as well. It's very dependent quite often on the type of lymphoma that you've been diagnosed as well. We can have either a curative intent for those lymphomas that can be cured. We'll be going as strong a treatment that you can cope with to be able to eliminate the cancer. We have the for disease control, so those patients have an incurable cancer, then we'll be trying to provide you with disease to get your disease under control or eliminate as well as we can. Or sometimes if for palliative, trying with symptom management. So making sure that we can try and reduce the tumour bulk to make you comfortable and extend your life there as well. Some of the baseline organ function. This is really important before they start treatment as well, and this can indicate if there's any issues and maybe they need to change a treatment plan depending on what these results show. A lot of lymphoma treatments do have, especially for a younger patient, do have an anthracycline. And anthracycline is a type of chemotherapy that's really quite active on a lot of different types of lymphoma, not for all. And doxorubicin is a good example of that. So this can actually unfortunately affect your heart. So it's very important that they check your heart before they start to make sure that you're actually going to cope with it and your body's going to be able to pump that chemotherapy through. Your kidney scans, making sure your renal function's okay. Some treatments such as bleomycin can affect your lung function. So they do tests to make sure your respiratory function is going to cope with that. We don't want to cause you long-lasting problems after your treatment. And these tests are often repeated during and after your treatment as well, just to make sure that your organ functions are still up to scratch and to help manage those if they're not. There are many different ways that chemotherapy can be given. And there's other different ways too, but these are the ways that can be given for lymphoma. There's intravenous, so via the vein in your hand or your arm is the most traditional that people know about. It can be given through a central access device, such as a PICC line, a portacath, through other central lines. And this is dependent on the type of treatment you're having, the length of treatment, and also the other factors such as poor venous access and things like that too. Some hospitals for particular treatments will actually put a PICC line in everyone. It's just very dependent too on the hospital that you're being treated at. Some treatments are given as an oral chemotherapy. And it might seem like they're less harsh, but some of these have just as harsher side effects as the IV version, so be aware, but that can be given that way. For those who have a high risk of like a disease that might reach the brain, they will give intrathecal chemotherapy into the spine. Subcut injections, so getting chemotherapy under your skin as an injection. And for some skin lymphomas, there are actually topical chemotherapies as well. Why chemotherapy protocols? Well, basically, the reason is lots of research have gone in over the years to look at how effective treatments are and what the optimum doses are for patients as well. And these are constantly being adjusted by many doctors around the place. And a lot of the protocols are actually named after the drugs that we've been treating you with. So for example, FC is fludarabine and cyclophosphamide, the two first letters of that name. So hence we've come up with some weird names, and that's the reason why. Different chemotherapies do work for different types of lymphomas and also for different cancers as well. So every person you might see in the chemo day unit, they're probably getting a completely different chemotherapy. It's a bit like, I always give the example of antibiotics. You wouldn't be treating every bug or virus with the same antibiotic. We don't treat every cancer with the same type of chemotherapy. And again, it's very individualised depending on your treatment, the treatment decisions made by your doctor from those factors I mentioned a bit earlier. And most treatments are actually combined with other chemotherapies or other drugs. So a reason why I spoke about the cell cycle earlier, and another reason why it's important to know about the cell cycle, and the reason why we make these protocols is that generally there's a combination of chemotherapy that we do. And the reason being is each drug actually affects a different phase of that cell cycle. You know, when the cells are dividing or growing or replicating itself. So they all have different little individual jobs. Some drugs just affect, such as at the top on the M, vinca alkaloids, they only affect when cells are about to divide. Other ones will affect when they're trying to replicate and make sure everything's okay in their DNA before they're ready to divide. Other ones can be non-cell specific. So they work on different pretty much all the different sides of the cell cycle. And these are usually, at least one of these are given with each protocol actually. So giving what we call an alkaline or non-cell specific. So this is like a basis that can attack cells no matter where they are at within that cell cycle. And also including those that are in the resting phase too. The reason why we give combination therapies is ultimately to help prevent resistance. So the different drugs target different parts of the cell cycle at the same time. And a lot of this hypothesis has come about from years ago when they were treating tuberculosis, where they're actually treating patients with different drugs at the same time, for that reason, trying to beat resistance, because they found they're giving one drug, the bug would change quite quickly and get resistant to it. So if you attack it with about 4 different types, well, it's very hard for that cancer to get too smart and become resistant. So hence the reason why we have multiple different drugs, and also the reason why I have multiple cycles to kill lymphoma cells as well. So if we didn't get it the first cycle in that particular cell cycle, because some of them, as I mentioned before, are very cell specific, depending on what part of the cell cycle they attack, they'll hopefully get in the next time round. And again, the combination chemotherapy is a couple examples of ABVD and CHOP, which I'll go through, and a lot of them are given in combination in immunotherapies. So ABVD is probably the most, as I said, the first one that came about, and what it does is, you can see with this one, the 4 different drugs are actually attacking 4 different parts of that cell cycle in that same protocol. So this is one for Hodgkin lymphoma. So we've got doxorubicin, which is an anthracycline that slows and stops the cell growth of cells, and it's by blocking a particular enzyme that makes cells divide. And we have dacarbazine, which is a non-specific alkaline agent, so hence it attacks the cell on all the different phases, including the resting phase. We have vinblastine that it kills cells when they're trying to divide, and bleomycin also affects them when they're preparing to divide. So again, attacking them from different angles to again get the best outcomes. I'll just very briefly mention this. I won't go into too much detail. And if you wanted to know more about monoclonal antibodies, Beck did a wonderful presentation last week. You can see on our website to talk more about monoclonal antibodies and how they work. But the 2 most common ones that we use is Rituximab and Obinutuzumab. And these basically work by binding, they're made in the laboratory, basically, and they mimic basically in general antibodies. So these basically bind to part of an antigen recognised by the drug, and they bind to a receptor or the CD20 on the surface of the B cells. And the aim of this treatment, basically, I didn't say that very eloquently, is that will stimulate the patient, when it binds to the patient's cells, it will stimulate the patient's immune system to attack the cancer cells, and also binds to some of the healthy cells too. But please see Beck's presentation to find out a bit more. And in recent clinical trials, there's actually a lot more other targeted therapies that are being trialled to see whether they can be done in combination with chemotherapy to, again, use the immune system to basically try and attack these cells too. And a good example of that is CHOP and a lot of different types of non-Hodgkin lymphomas, treating with an immunotherapy to try and bind to those cancer cells, treating with an alkaline agent such as cyclophosphamide, doxorubicin again, and the anthracycline. And prednisolone is a sneaky one where a lot of people don't realise it actually has a lot of cytotoxic, so toxic to cells when it's given in a higher dose. So this is the reason why prednisolone is often in a lot of lymphoma treatments, because it can actually help stimulate the cells and make them more sensitive, the lymphoma cells, and also get them out of the resting phase a little bit too. So it has a really good quality and usage in lymphomas. The reason why we now use Rituximab or R-CHOP, and this is a trial that happened about 7 years after Rituximab was released from the Gala trial back in 2007, which compared R-CHOP to just the standard CHOP, just chemotherapy alone. And it was found with the addition of Rituximab to CHOP that the outcomes for patients improved by 15 to 20%, which is very significant. And it's similar to other types of lymphoma too. So it's very a great drug, and this is had the rise for a lot of the combination therapies with immunotherapies, which they're trying to still improve upon. I'll just briefly mention this one's an antibody drug conjugate, which is used for CD30 positive. So the other one was CD20 Rituximab. This one's a CD30 positive, and usually used in Hodgkin lymphoma, anaplastic large cell lymphoma, and cutaneous lymphomas. And this drug, they did try to make it similar to Rituximab, where it then binds to the CD30 receptor on the cells. However, it wasn't working as well. It wasn't attaching as well. It wasn't working as well for some reason. So they decided to bind this with a chemotherapy to the surface of these monoclonal antibodies. So these monoclonal antibodies attach to the CD30 cells. They're floating around, and then they leach in this chemotherapy directly into the cell, similar like vincristine. The drug is, so hence the similar sort of side effects that it does create, unfortunately, with vincristine, and kills the cells that way. So there's a few more drugs that are coming through the ranks at the moment, are using the same sort of way of doing things, very targeted therapy. While we have chemotherapy cycles, well, basically 6 cycles can be have treatment over 1 day, and then you have a 3-week break, or they can be given over many days per cycle. So the number in cycles is very dependent on different individual factors, the type of subtype you have, and also your individual factors as well on the stage. Chemotherapy aims to kill the cancer cells by ultimately causing as little amount of damage to you in the healthy cells as they possibly can. The aim is to kill more lymphocytes with each cycle, and I'll try and explain that in a little bit more detail in a moment. And the rest between cycles or treatments allows for the normal cells time to recover from damage. And it's usually the shortest amount of time that you need for those good cells, especially immune cells, to the neutrophils, to come back, so then they can treat you with more chemotherapy. The cell phase specific chemotherapies also need repeated doses, because they're only targeting that particular part of the cell cycle division at each cycle. So then they need another cycle to be able to keep tackling that same part. So the best outcomes is actually try and keep you as well as we can through cycles, so and keeping the cycles on time, because we don't want the cells to sort of start to grow a bit more. We want to keep you as healthy as well in between there, so we have it on time. Now, this is quite a confusing thing, but this is the whole hypothesis of why we give chemotherapy cycles, and why you need to have more cycles than, say, after your staging scan. I get this question quite a lot, is that I've had my staging scan after, say, cycle 2 or 3. There's no chemotherapy, there's no signs of disease, so why do I need to continue with the remainder of the cycles? And I get that question quite a lot, and this is the reason why. So lymphoma cells divide millions and millions of times before they're actually seen on a PET scan. So on the left-hand column is the cancer cells, a number of cancer cells. And basically they need to divide like 10 to the 9 million times before they're about a centimetre, showing a centimetre tumour that you can actually detect on a PET scan. So without treatment, obviously the number of cells will continue to grow, and we don't want that, so that we're starting to overtake the host. So chemotherapy ultimately aims to kill a proportion of cancer cells, including good cells, unfortunately, with each cycle. And this is why you need multiple cycles, even if the scans do not show any more lymphoma. And research has found that you need to finish all the cycles of chemo to ensure that all cells, including the cells we can't see, have been destroyed. So this is the log cell hypothesis, which basically proposes this model for the effect of cytotoxic chemotherapy in the amount of lymphoma. So for every dose of chemotherapy kills the same amount of fraction or proportion of the cancer cells that you have in your body. Okay, regardless of the number that are there, it'll kill a proportion each cycle. The faster the growing the cancer cell, and this rings particularly true for the aggressive lymphomas, they're very sensitive to chemotherapy. So hence it's always going to be the number one treatment for a lot of these therapies. And this is why it's given in combination as well, so we can try and attack it in different ways as well and keep ahead of the cell growth. So basically, get this little thing to work. After each cycle, so you see up the top here, this is the start of treatment, okay? So just imagine it's the imaginary line when we can actually see your cancer on a PET scan, for instance. You'll have your first cycle, and that will kill a percentage of that cell. And this is basically, you'll reduce the number of cancer cells in your body. In between your cycle, you'll then get a regrowth, okay, of cells. And then they will hit you with the second chemotherapy dosage. A little bit's growing back a little bit. They hit you with a bit more. And this will actually kill another big percentage of cells. Then they'll grow back slightly more until you then keep continuing with another cycle. And this will continue on until we've got no more cancer cells is the ultimate outcome, okay? So it's all this in here that we know that there's cancer cells there, but we might not be able to see them. So they want to make sure that we get all those sneaky ones are in the mix or in the resting phase and make sure we get it all. So it was a bit heavy going, all of that. So I'll go into a little bit of it, finishing off with what to expect once you've had chemotherapy, and we're going to answer some questions in a moment. So what to expect, so chemo can be given in an outpatient or as an inpatient, sometimes at home as well, not so often for lymphoma treatments because they are a little bit more, a few more side effects and things. So but I recommend people drinking plenty a day or two before they go in for treatment. And this is to make sure you're well hydrated, your veins are at their best. And if you do feel unwell after your treatment, at least you're hydrated. You're not trying to catch up, keep getting yourself hydrated before you're feeling unwell, not forcing yourself to drink. Eat normally unless otherwise requested to, and in case you had a special blood test or a test, but generally trying to have something in your tummy does help and helps with nausea too. Bring a friend or some entertainment. You should get some education prior to your treatment. If not, definitely ask. I wouldn't expect you to get it without any education. Shouldn't be painful. It should just feel cold. Please tell your nurse if you have any issues. Tell your team about any medications that you're on, and particularly complementary therapies or vitamins or other nutrients. Some of these actually can interfere quite negatively with chemotherapy. So it's really important. Even something like vitamin C can actually make some chemotherapies more toxic. So you don't want that. And ensure before you leave the chemotherapy department that you have an emergency plan. Have contact details, know who to call, and what you need to report when you leave the centre. At home, chemotherapy is going to be in your system for a good 48 to 7 days, depending on the type of treatment. And that chemotherapy means that something in your body fluids like vomit, blood, urine, semen. So it's really important to use precautions, say when you're having sex, just to make sure that you're protecting your partner as well, and family to use gloves and soapy water to clean up as well. Good hygiene is really important. Washing your hands, keeping your bench tops clean, all that sort of thing. Safe food preparation is important. Having well-cooked food, because we don't want you getting any bugs or grubs, especially when your blood counts are at their lowest. Keep the sick people away. Avoid crowded places, especially when your counts are low. And wearing a face mask when you're low, and particularly if you're in Melbourne like me, you have to wear it anyway. These are some of the common side effects, and I'm very conscious of time, so we won't be able to go through a lot of them, but I'm very happy to answer any individual questions that come through, and we can probably do this at another session, talking more detail about side effects and how to deal with them. But the main common ones are probably nausea and vomiting, your low blood counts, having infection risk, gastrointestinal symptoms, and fatigue are probably the biggest ones, and I'll go through them quickly before I finish up. I mentioned a few times there's healthier cells that are affected with rapidly dividing cells, and the rapidly dividing healthy cells are your bone marrow, your blood cells, your gastrointestinal mucosa, hair follicles and skin cells, and also other ones can be even like say sperm, and depending on the type of treatment that you're having. Bone marrow, I thought we could just quickly run through. This is really quite important, especially for lymphoma patients, because obviously the chemotherapy that we're using, we're trying to attack your immune system because we're trying to kill those nasty lymphocytes. So hence you get a lot more of these sort of symptoms. Red blood cells, and this is quite interesting to know because these questions I often get, is that red blood cells that have a lifespan of 120 days, meaning that they can sometimes be slower to sort of reduce in number, and they can actually be slower to recover at the end of treatment as well. So they can be a little bit low for a while, and that causes side effects with low hemoglobin. So meaning you can be short of breath, more fatigued, and less energy. So keep your doctor in check. We don't often transfuse unless you're really quite low, but and symptomatic. But yeah, it's something to let your doctor know how you're feeling. Platelets have about 8 to 12 days, so they replace themselves quite quickly and they recover quite quickly after treatment. White blood cells, usually about 13 to 20 days, and that's usually the cycle links, usually to make sure those cells are back to normalish levels. So you've got some immune system to help fight any bugs. And lymphocytes, which we are trying to attack, really get knocked around. And memory cells can sometimes take, their lifespan is actually years, and other cells such as lymphocytes can be weeks. So these are quite slow to recover quite often after treatment. And this is why quite often people do have a lot of colds and flus after treatment. It can take 3 to 6 months sometimes for those levels to come back. Your neutrophils might recover quite quickly because they've got a quicker lifespan, but lymphocytes can take weeks. So hence the reason why you might get a few issues. This is a chart I provide to my patients, and I cheekily did it on the screen, which I'm pretty impressed with myself. But this is based on a 3 to 6 cycles. So depending on the chemo you're having is how long the cycle is. And this just shows how your blood counts are tracking throughout a cycle. So day 1, this is when the chemotherapy starts. This is when your blood cells are at their optimum and you're ready for treatment. Usually takes about 4 to 5 days, and you're probably feeling yourself when you start to feel tired and not so well. It's basically when your blood counts start to decrease, okay? And usually in the middle of the cycle, between days 7 to 12, is what we call the nadir. And this is when your blood counts are really at the rock bottom. And this is when you're going to feel the most tiredest. This is when you're going to be the most prone to infections. And this is when you really need to probably lay low and keep away from a nasty bugs and stuff like that. About to day 14 or so, the blood counts start to recover, and then they should be back to some sort of normalish level just before we hit you with more treatment. Okay, so that's the shortest amount of time for your immune system cells to be ready and grow back and keep you as safe as possible. So that's the theory behind the cycles. Just briefly about infection risk and neutropenia. During that time, it's really important you contact your medical team if you have a fever, having chills or sweats or shivers or shakes or any signs of infection. Let your medical team know, because your immune system's not there to help fight these infections that you normally can do. And you can get sick, for particularly some types of treatment, with really make you really sick, rock bottom. It's really important to report that and get onto antibiotics as soon as possible. With infection risk, how to help, making sure you keep as healthy as possible. Infections can be airborne, all sorts of ways you can catch them. You'll be given a GCSF injections, particularly for the more intense treatments. And just sort of put a side note here because a lot of people call in about this question. They can cause a lot of bone pain, especially around your lower back region. That's where most of your bone marrow, your blood cells are produced. Usually Panadol and a heat pack is okay to sort of get through it, but some patients do actually find it really, really painful and need stronger painkillers. But another little thing, it is an inflammatory response. So your cells are really fighting back. An inflammatory response can help. So having an antihistamine that you can get over the counter at a chemist actually does help with that pain. But preventing infection is the best. Check with your doctors if you need a flu vax or any other type of vaccination. Washing your hands, particularly after touching pets and animals, and gardening and swimming in gyms, be very, very careful. That's where a lot of bugs love to hide. Keeping away from sick families, and washing hands is the most important thing, especially with COVID times. That's when we're really being drummed into us at the moment. Just finishing off quickly, so we can ask some questions. Gastrointestinal symptoms can occur, and that's because your mucosal lining right down from your mouth right to your bottom can be affected. So nausea and vomiting is also receptors in your tummy. Mucositis, like mouth ulcers, and that can happen right down your whole your tract. That can cause all these symptoms: esophagitis, gastritis, reflux, diarrhea, and also constipation. Fatigue is probably the most common side effect that most people experience, 9 out of 10. For those people who are more interested in finding out some tips and tricks to help with your fatigue, we've got a presentation next week with Rebecca, who'll be talking about fatigue. So tune into that. I won't go into too much detail, and it can last for many, many months. I'll just sort of skiddy through some of these. Peripheral neuropathy is quite a difficult one with a lot of the chemotherapies that we provide for lymphoma. It can damage the nerves. It can mainly happens in the feet and the hands, and symptoms can be really, really uncomfortable. So preventing injury is probably the most important. You can have painkillers. Sometimes acupuncture can help, but also getting a review with an OT. This can be a symptom that can be really quite debilitating for a lot of people. Keeping healthy is during treatment is the most important thing to get you through. Exercise is really helpful to help with fatigue as well. Balanced diet, reducing or preventing infection, good hygiene, keep away from sick people, drink heaps of water is very helpful. Flu vaccination, especially in the winter periods, and maybe even need a booster. Just speak to your doctor about that one. And just finally, last slide, I promise. Basically, what happens after treatment is you'll get a scan afterwards just to see and make sure the treatment has worked. There's no, if there's still no lymphoma there, that's a really great sign. You'll have follow-up care to make sure that everything's going well. You won't have scans. I'll mainly do physical and making sure your blood counts are recovering, making sure your side effects are starting to resolve. But physical recovery can really take a good while, and everyone's very different. Early recovery phase can be 3 months, but some people can take 3 to 12 months, and it can take even longer for some people. So it's very different. So just be aware you won't go straight back to normal. There is a recovery phase, and we'll be talking about survivorship or post-treatment side effects at a later date through these sessions. But the mental and emotional recovery can take some time, and some people can report being fine until even 6 months after treatment when they start to think about what they've been through, and it can be a troubling time. So it is an ongoing process. But I'm very open to taking questions now. Thank you. You there, Beck? Hello. Oh,
hello.
That's all right.
I haven't run away. Thanks, Donna. That was fantastic.
A lot of information, I know, but I'm open to any questions. Thank you.
Are you able to see the questions, Donna, or would you like me to read them out for you?
Yes, I can see them now. Yep. So, this is from Megan. So my goddaughter, now 6, was diagnosed with non-Hodgkin's lymphoma on her 3rd birthday and is on the verge of full remission. That's great to hear. She had a staph infection just after a stem cell transplant, which then failed. What is the chance of her having non-Hodgkin's lymphoma again as she gets older? It's a very good question, and I guess it's something that we really don't know the answer for, unfortunately. With children, and a lot of the types of lymphoma that kids do get are generally more often than not curable. So I'm hoping your goddaughter is in that mix as well. With the problem with, I guess, with children having chemotherapies or any other type of treatment is that it can affect the DNA for future, like late effects, we call it, or secondary cancers that can occur later down the track. And that's why it's really important that your goddaughter then can actually get your complete follow-up and keep that follow-up going to make sure they get on top of it quicker rather than later. I hope that answers the question. Okay, but we're also putting a lot more information about children lymphomas on a new website very shortly too. So please email me if I haven't answered your question properly as well. Rebecca Irwin, when you finished chemo cycles, for how long after chemo is your immune system still weaker and more susceptible to infections, etc.? So yeah, great question. And it's not a matter of finishing treatment, as I mentioned a minute ago, and then getting back into normal life. So it takes a good month for your basic neutrophils and to actually recover. So your immune system has got some immunity, usually about 3 to 4 weeks later, depending. Some people might take a little longer. But as for that, the lymphocytes, so your antibody immunity and your longer immunity, that can take a good 3 to 6 months to sort of get back into some sort of track. So a lot of patients do find they get a lot of colds and flus for many months afterwards, including and teeth problems as well, so infections in their teeth too, because the immune system's not completely 100%, because we have attacked you with chemotherapy that's affecting the lymphocytes, which is your longer immunity. So hence it's going to be usually a little bit more suppressed for a good while. Excellent. Did I answer your questions? There's no more, but thank you for the lovely feedback I've got on there. Thank you, Jody and Lynn as well. Have any more questions? Oh, hang on, Carol. Is there a recommended time frame that you should keep your portacath in after completing treatment? Most people keep it in for probably up to 3 months, just until you've had your last scans, making sure everything is looking okay. If you're having maintenance therapy, they generally will take it out earlier rather than later, usually after a week or so after treatment, actually, once they know your immune system's sort of recovered a little bit. It can be a couple of weeks. But if you finish like a longer term chemotherapy treatment, they will generally wait for probably about 2 to 4 weeks after you finish chemo, just to make sure that your blood counts are recovered, like your platelets, for instance, because they don't want you bleeding, and also to make sure you have some neutrophils there to fight any infections that can occur maybe once you've taken the portacath out. You try to get them out quickly. PICC lines you can take out really quickly, generally after on the last day of treatment, or once they've had their week blood test after treatment, we usually get them out pretty quickly. Anonymous, can you discuss the impact of doxy on the heart? So yeah, this is quite an awful one for a lot of patients. So basically doxorubicin affects the heart by basically pretty much ages the heart. So it affects different the cells and the cell muscle, and it can actually age the heart. So patients who have to do with the anyway, it damages the heart muscles anyway. So basically people will have a scan during the your treatment, and this can show whether it's actually affected the function of your heart with the muscles, and it isn't actually able to compress. What's the word I'm trying to think of? Pump out. It alters the ability for your heart to be able to pump blood, basically. So some patients can actually damage it permanently. There are some patients who we might need to reduce your anthracycline dose for a little while, and sometimes it will cover. But I have had patients, even young patients, even 20 years of age sort of thing, where the drug has actually really has affected, and patients have had to go on to medication to help with the pumping of the heart. It can age the heart, so late effects can be an issue too, and it's really important to keep up your follow-up care with after having doxorubicin. There is a recommendation that you generally do get a test done a couple of years after your treatment. Also, something for younger patients as well, when they're about to get pregnant, it's a really important thing to let your obstetrician know as well that you've had doxorubicin in the past, and especially if you've had altered tests during your treatment as well. The reason being, with pregnancy, our bodies make a lot more blood, and so hence patients can have heart problems when they're pregnant. So it's something to keep in your back of your mind and letting your future doctors know in the future. And some patients have actually had heart disease 20, 30 years later. And if you're a young person, 20, 30 years is not that, you're not that old. So something to keep in the back of your mind. Another anonymous, what are privileged areas of the body in relation to chemo? Can these escape the chemo? Or privileged, meaning, I guess, if there's any cells that can hide, I'm assuming. Privileged area, there's a lot of drugs that actually don't cross the brain spine barrier. Okay, there's only a couple that will, and methotrexate, for instance, one, and that's you might have it in high doses that can actually cross the brain barrier. So this is where the problems can arise with some certain types of lymphoma, and that's why if there is a high risk or you have high risk of maybe the disease moving into your brain, they will give you lumbar punctures to try and put the chemotherapy straight into your spinal canal to try and kill and prevent any of those sort of side effects. So that's where the chemotherapy will be injected that way instead. But otherwise, that's pretty much the main parts that won't go. It can go everywhere else. Anywhere there's a blood supply, which is most places. I think we've answered all our questions. Is there any more questions? No, I think we're... Oh, I've just found one in the chat room. After R-CHOP, what are cancers that can crop up? So the main cancers that crop up are from the anthracyclines, actually. So the doxorubicin, the red one, or the red devil, a lot of people call it, in the R-CHOP. And unfortunately, about 1%, so it's very, very small risk, but roughly about 1% can go on to develop something like an acute leukemia or some sort of related disorder. So 1% is very, very small. And again, that's why it's so important for you to keep a track with your doctors, keep up with your regular blood tests and things like that, so they can monitor that. And that quite often won't happen for most people 5 to 10 years after treatment as well. All right, I think we're...
I think one more has just come through, Donna.
Come through. Oh, yes, they are. From someone, do many patients choose to refuse chemo based on the possible impacts? Look, there are some patients who choose not to have treatment, and I've had a few patients over the years that have gone down alternative therapies. It's a tough one, and I respect people's, it's your life and your opinion, and it's good to get a couple of opinions and getting all the information that you need to make that decision for yourself. But in my experience, chemotherapy, or depending on the type of lymphoma that you do have, that standard treatment is proven to work. And I guess a lot of these alternative therapies aren't proven to work. And I'll be looking at definitely where the scientific evidence is to some of them. So it's definitely a good question to have with your doctors and to get all the answers that you need to make that decision. It's a tough one. Kelly, I read that if a tumour breaks down fast, it can go into the bloodstream. What does this mean for someone? Yeah, no, this is a really good question. This is really important, particularly for patients who have a lot of cancer in their system. So the chemotherapy, especially some of the more intense therapies, they can really kill the cancer cells really, really fast. And as you alluded to, they do break off and go into your system. the cancer cells have all these electrolytes and toxins that can be quite toxic for the body if they're overloaded with some of these electrolytes into the body. And the main ones, and it's called what we call tumor-lysis, actually. It's a cell breakdown. And all the contents of those cancer cells, if they're all broken quite quickly and go into the bloodstream, they can release high doses of, say, potassium in your system, urate, which is and can block up your kidneys. So it's really important if this happens, if we know someone has a lot of tumor in their system, is making sure they're well hydrated. So we want to make sure the kidneys and flushing out all these bad toxins from the cancer cells as quickly as we can, and protecting your kidneys as much as we possibly can too. And doctors are getting a lot better at predicting patients who might have this issue, where they might give you something called allopurinol, which helps reduce that urate level and help protect your kidneys. And also they might give you something like high-dose steroids for a few days before you start treatment to try and reduce the tumour bulk down a little bit. So when you do have the first day of chemotherapy, it doesn't affect you as much. So they're getting a lot better at recognising patients that this can occur and making sure that you're well supported through that. A very good question though. And Linda has asked, can the neuropathy come and go after treatment has ceased? Yes, it can, unfortunately. Generally, most people, if they do get peripheral neuropathy through treatment, and once the drug, usually vincristine is probably the most common drug that causes neuropathy, and that's in CHOP, has been ceased. Generally, nerves can take the longest cells that can take to recover, and sometimes they can take months, even a couple of years for some people if it's really severe. So that's why it's really important to let your doctor know as soon as you start feeling those symptoms during treatment, so they can maybe reduce the drug or omit that drug that might be causing it. It can occur sometimes a delay neuropathy. I've seen that happen with some people. And neuropathy can occur, as I mentioned quickly, I know I rushed through those last few slides, in your hands or your feet, but it can also occur in other parts of your body too, and like nerve pain in your legs, in your jaw, all sorts of different places, really weird places, but they're the main places. It can affect some people after treatment, where they might have some balance issues or some little bit of numbness in the fingers, and depending on how bad it is, it generally does recover over time. But there are medications that can help with the discomfort, but also preventing injury is probably the most important. And there's also some people try acupuncture and things like that can actually help with your neuropathy too. I think I've answered all the questions. But please, you can always email any of the nurses and we can try and answer any of these questions. We can talk all day with just the common side effects, and there's so many and everyone's completely different. So yeah, please reach out, and thank you for joining me today. Thanks, Beck.
Thanks, Donna. That was awesome. Thank you.